My name's Richard Shaw. I'm from the University of Liverpool, and I'm presenting today on behalf of the COVIDSurg Collaborative on head and neck cancer surgery during the COVID-19 pandemic, an international multicentre observational cohort study. This presentation's come off the back of two recent publications. The first one from the collaborative looks at the complications in patients who have surgery with known diagnosis of SARS-CoV-2, and the results are disappointing. The overall mortality of 1,100 odd patients is 24%, and 51% have severe pulmonary complications. So surgery in patients with COVID-19 is a very dangerous issue and should be avoided if possible. The second paper is establishing the value of COVID-free surgical pathways for cancer surgery. This is looking at elective cancer surgery in over 9,000 patients, whereby the mortality and pulmonary complications can be halved, roughly speaking, by using COVID-free pathways. So the background for the study on head and neck cancers is that this is a group of sometimes rapidly growing tumours for whom therapy is reliant on primary surgery. Delays are unacceptable, palliation is difficult. But also there's significant risk to healthcare workers because there's multiple airway generating procedures in the airway, and in fact there have been early reports of deaths in head and neck clinicians. We've had some opinion-based guidance to avoid many of our more complex surgical procedures which have left us in a dilemma. The aims of this study, looking at surgery carried out in the first 3 months of the pandemic. For many centres this was approximately March to May. Looking at safety to patients and surgical teams, and looking at what changed in treatment in terms of therapeutic migration or de-escalation. The methods: this is an international observational study carried out by REDCap. It's routine anonymous data for 3 months and consecutive adult patients with head and neck cancer surgery with curative intent. The outcome measures: the primary outcome measure was severe pulmonary complications with a positive SARS-CoV-2 swab or a clinical diagnosis of COVID-19. We have several secondary outcome measures, including mortality, complications over 30 days, and whether a member of the surgical team develops COVID within 30 days. The data I'm presenting today is on 1,137 patients in 133 hospitals over 26 countries. Countries with a high exposure to COVID-19 are well represented, as shown, and much of the surgery was carried out for oral cavity, thyroid and skin cancer. Most of the hospital sites were characterised as hot, i.e. they had admissions with COVID-19 as well as the cancer surgery, and at this time just over half the patients were screened for SARS-CoV-2 prior to admission, remembering that COVID testing was not widely available at this time. The results: so patient safety. So 29 or 3% of patients developed COVID-19 or SARS-CoV-2 within 30 days of their surgery. 13 of these patients developed severe pulmonary complications, and there were 3 deaths known to be due to COVID-19. So one way of looking at the reasonably safe profile, but in keeping with the earlier paper, there's quite a high incidence of severe pulmonary complications from surgery with people with COVID-19 and a reasonably high mortality. The complication profile otherwise was unremarkable, and the overall 30-day mortality was 1.2%, which is in keeping with head and neck surgery in the broader sense. Looking at associations, so in terms of severe pulmonary complications, there were a positive association with larger tumours and higher end stage. But notably, there were no associations with older patients, less fit patients, specific tumour sites, or complex procedures such as free flap reconstruction or tracheostomy. In terms of clinician safety, after 3% of the operations, that's 40 of the operations, a member of the surgical team developed COVID-19. There was a strong association where the patient was positive. In fact, 24% of cases where the patient was positive, at least one member of the surgical team developed COVID. we didn't collect data on outcomes. As we have data for the background community infection rate for all the hospitals, we can estimate that the clinician infection rate was an order of magnitude higher than the background community. The associations where the clinician was positive were, as I said, where the patient was positive, which was the strongest, if there was a high community incidence of COVID in oral cavity subsite, in tracheostomy patients, and where there were other surgical complications. In conclusion, head and neck surgery was safe during the COVID pandemic, even when the surgery was complex and prolonged. There was an overlap between patients and surgeons developing COVID-19, and this likely reflects failing in testing cross-infection or PPE. Based on this data, significant therapeutic migration away from surgery or de-escalation of surgery is not justified. Future work has included fundraising to expand the scope of this work both in breadth and depth, looking at 2-year survival and functional outcomes. I'd like to thank the leadership of the COVIDSurg group in Birmingham and my colleagues in the head and neck community, both in the UK and abroad, help in putting this large study together. Thank you.